Our last speaker of the day, certainly not the least. Dr. Karen McCulloch is a professor in the Division of Physical Therapy in the School of Medicine at the University of North Carolina at Chapel Hill. Her clinical and research focus is in neurorehabilitation, has been traumatic brain injury and concussion. Her current research is focused on return to duty assessment after MTBI in military populations. And she is co-lead on the clinical practice guideline development for physical therapy after concussion at the UNC Matthew Gefeller Sport-Related TBI Research Center. Please welcome Dr. Karen McCulloch.
So I'm all that stands between your tour of the big house, and I'll try and make it worth your while. I just want to get a little bit more of a sense of who's in the room. I saw the athletic training hands earlier. How about, are there any physical therapists who are here? Okay, cool. Any physicians? A couple? Yeah, great. Anybody who sort of classifies themselves as a researcher? Yeah? Okay. All right. Is anyone seeing non-sports related concussion in their practice? Okay. How about military? Okay. All right, good. My peeps. All right. So as Steve mentioned, I'm currently kind of very much immersed in a niche, so not as much focused on sports concussion, but dealing with tactical athletes, that you might say, with a number of DoD projects. So just so you know, that's kind of where my headspace is. Including some things where we're really looking at the use of dual and multitask assessment to try and help therapists and providers make return to duty decisions in the active duty population. We have a couple of projects where we're looking at rehabilitation interventions and at the Intrepid Spirit Centers, which is in the military context is an outpatient rehab program that's specifically focused on TBI. So I have some experience related to that, and I've been involved in an active rehab study that John, our Register McCulloch, has been leading up at UNC, where that's more my bridge over to sports concussion, and results for that should be coming out pretty soon. I can't really talk about the details of that today, but one of the first kind of large randomized control trials, I think, to look at an earlier initiation of rehab, really days after someone's had a concussion, as opposed to waiting until they become asymptomatic. So that's something that you should look for. Frontiers in Neurology is where that we've submitted the methods paper for that, so you can look for that. So I'm going to share some perspective too from a clinical practice guideline development group that I've been co-leading for American Physical Therapy Association. So I'm sort of a neuro geek PT, but the group involves folks from sports, from peds, from orthopedics, and neuro. And we've been thinking about, we're about to release the kind of our draft of this. So if anyone has an interest in giving us feedback about it, then you should give me your contact information, because we could use that. In our sort of thought about concussion in general, we've really thought about the type of impact that happens, the mechanisms of injury that people have, and this is thinking more broadly than just sports concussion, that there may be additional injuries beyond the concussion itself that are the things that might bring people to a more specialized rehab context, right? So, I'm recognizing that you as an athletic trainer, for instance, you are doing rehab and returning someone to play, but if it's a relatively straightforward course and they don't have residual symptoms that are really prolonged, then you're following the Berlin guidance and progressing in that way. When I tend to think about traumatic brain injury rehab, I'm thinking about people that have maybe a little bit more severe involvement with some residual impairments that you can identify with clinical testing and may need some really specific interventions in order to help with those things. So in our physical therapist group, we're framing our discussion about in this clinical practice guideline around what we call a concussive event, because there is so much the potential to have cervical injury, also the potential to have some sort of vestibular injury or vestibular involvement that occurs because of the forces that are involved in an injury. So we have found that to be a little bit more broad, and also helps us really even within the profession of physical therapy to get out of our little silos, because we have our ortho PT is like, oh, it's the neck that's the problem. And we have a neuro PT that's like, oh, it's the vestibular system that's the problem. And it could be that it's both, So trying to get people to sort of think a little bit more broadly about multiple contributors to complaints that patients might have. So when I think about the rehab process, having done TBI rehab for my entire career, it's kind of a continual sort of shift from looking at the forest, big picture with your person that you see in front of you, to looking at the trees. Like, what are the individual factors that might really influence their progression in some way? So kind of back and forth, this forest versus tree issue is something that I think is helpful to think about. In the rehab disciplines, this framework, the International Classification of Function framework, is a very common approach that people use across all different sorts of disorders. So is this a framework that you all have seen? Who's seen the ICF framework before? Anyone? Mostly probably our PTs that are in the group. Okay, so this is, consistent with the theme of the conference, that we're thinking about being holistic and how you're considering the mind, body, spirit. I think the ICF suits that really well, and it also helps you think about potential confounders that might prolong someone's recovery. So you think about a health condition like a concussion, and there may be some underlying pathology. In the original version of this model, there was a block off to the left where the 2 is that said pathology. So that might be some of those DTI findings that we heard people talking about earlier. And then you can identify specific impairments that result from that pathology. So maybe it's a vergence problem, maybe it's a vestibular ocular reflex impairment that you are able to identify when you do your clinical testing. And those things may then influence activities that people are willing to do. So I can't read as long, I can't work at the computer as much. I get really motion sick now when I wasn't before. So I'm not riding in the car, or I have to sit in the front seat, whatever sort of activity things there might be. And then those continue over to the participation level, and participation is really about life roles that people play. So there's been a lot of focus here about the athlete, and certainly if you work with professional athletes, there's big overlap with their sport and their job, but for someone maybe who's a college athlete, at some point they might not be an athlete in the strict sense of my sport is the most important thing that I'm doing. So I'd encourage you to think about life roles broadly: student, military service role, your role in the family, your role as a parent, those sorts of things. So those participation roles may be influenced by this impairment that causes activity limitations that then causes participation restrictions. Now, the contextual factors are really important ones, because the environmental factors are things that are present within the environment that might facilitate or be barriers to the person being able to fulfill their participation roles that they want to do. So you have a school system that's very willing to work with someone that needs accommodations for a return to learn sort of program. So that's an example there. Personal factors are things where you might think about, migraine headache history or ADD history, those sorts of things, kind of contextual factors that may result in a prolonged recovery in some way. So these are, this model is something that you can use to think about. I'm sure you in the back can see all the details here, but this is from a paper that a good buddy of mine who's active duty in the Army, Matt Scherer, wrote about applying this model to return to duty determination, and it's informed kind of the way that we think about it with the group that I work with now, where we think about musculoskeletal, vestibular, auditory, or cognitive impairments that could occur way over on the left side, body structure and function domains. Warrior tasks, the ability to move under fire and maintain situational awareness that are activities. And then those could influence the person's ability to be a member of a dismounted patrol and do that role in a way that's consistent with their unit safety and that sort of thing. So you can have environmental factors that might serve as barriers or facilitators, like I said. And likewise, you could have personal factors that could serve as kind of negatives or positives. So I think that's something that deserves some attention. We tend to focus on things that might be more negative as prognostic factors that would influence recovery. But there are also some really positive factors like resilience and self-efficacy that are probably important in someone's recovery after a concussion. So those are things that we could think about. So, we're talking about the brain and an injury to the brain, an organ that is the most complex that we have, that accomplishes so many different things. So we have to expect that there's going to be heterogeneity in the way that our patients might present and what their needs might be. So the idea that, yes, it's reasonable to have a protocol in the early phases to protect the person and then make sure they're not going back to play too early and that sort of thing. But if someone has residual symptoms, I would be surprised if there's a protocol that would suit that, to be able to describe all of the variations that you might see. And people have said that earlier, you've seen one concussion, because it's an injury to the brain, right? So we have to really think about what those complexities might look like and how we might be able to address those in a rehab context. So we've heard discussion about early recovery, and so you may be in a role where you're starting a return to activity after someone's had their day or two of rest, depending on which what context you're working in. In the military, it's 24 hours with their current guidance. And you're gradually having them resume their typical activities. Think about environmental factors that you might be able to incorporate to facilitate recovery. And think about personal factors that might prolong recovery, and you're educating them about, what you expect the time course would be and that you expect recovery, right? So setting that mindset that recovery is something that's reasonable to anticipate. Now, if someone has more persistent limitations or complaints, then I think the first line of defense is to try and address headache and sleep issues, because a lot of times if you deal with those problems first, then some of the other subjective complaints that people have will go away. So their cognitive complaints may be reduced because now they're getting a good night's sleep. Or they're not dealing with an ongoing headache problem. And then, if there still are persistent complaints that people are presenting with, I think that's where we have to shift from just asking them about symptoms, but to try and identify some underlying impairments and go kind of think about that ICF model that are causing functional limitations for them or participation restrictions. So, we know we want to get people back to activity, and I feel really strongly that exercise is medicine. So I picked my favorite form of exercise right here, especially if it's outdoors. But I want you to think about self-report has significant value in that early diagnosis phase, but as we move more into a persistent symptom presentation, we might want to think more about what physical signs we can identify, because that's going to point to something we might be able to treat. So as you consider that, you have tools that have been discussed here, the SCAT-5 that includes a post-concussion checklist and a way to characterize the symptom complaints that people have. But depending on the presentation that your patient has, a general checklist might not be specific enough for the problem that they have. Okay, so I'd encourage you to think of, maybe use the general symptom checklist as if you're thinking, oh, this person's going to need rehab in kind of a multidisciplinary way. That may give you an idea of where you need to go, but there's only 3 items about dizziness on the typical generic checklist. And there are other measures that are self-report that are a lot more detailed about a particular complaint of dizziness, like the Dizziness Handicap Inventory or the Visual Vertigo Scale. So it may be important to make a shift to a self-report measure that's more targeting the problem that your patient has if you're going to need to do ongoing rehab with them. All right, so one of the things that I think is really important to think about with the rehab mindset, and I see at least a couple people who know who this is. I know when my memes don't work, and I know I'm getting old, right? But I encourage you not to go it alone, like the Black Knight, but really to think about a team, because then you get coconuts, when you're, because no one does more moderate to severe TBI rehab by themselves. It's really important to have a team of individuals that can deal with different impairments that emerge, and you're not just dealing with, trying to do everything on your own, because no one can be an expert in everything that's a possible impairment after TBI. So I've got kind of some suggestions about functional problems. Again, so you're thinking about what is the functional problem, that functional limitation that the person is complaining about, and then different partners that you as athletic trainers, since that most of you all are here are athletic trainers, people you might reach out to that might have more specific training in managing cervical complaints. So look for a PT that's a sports or orthopedic certified specialist. There's a manual therapist specialty. Cognitive complaints, there's a long history in traumatic brain injury rehab of collaboration with neuropsychology, occupational therapy, and speech-language pathology to manage the testing and the treatment related to cognitive impairments. There's an OT specialty in driving assessment. So that's a really important thing. If you're dealing with people with sports concussion, are they safe to go back to driving? I would urge you to try and seek out a professional that has specific training, and they have driving simulators that can really look at reaction time and help you make a decision about that, instead of trying to figure that out in a way that hasn't really been validated. If you have somebody that has dizziness complaints, to say that you're dizzy that's just a word that doesn't have clear meaning. So you really need to get more at, well, what do you mean by that? And that may involve a neurotologist, ENT, or an audiologist who does more diagnostic testing, or look for a physical therapist that has an NCS, a neurospecialty credential. There's a vestibular competency course that's sort of the standard for PTs to do postgraduate additional training in vestibular rehab, or someone that's listed on the Vestibular Disorders website. And then I think it's really important to have someone you could refer to who can handle visual problems. So people that are, typically these are folks that have more of a developmental focus in their visual rehab or a neurooptometric rehab focus. So you can find members or fellows in those organizations on the at the websites that you see listed there. And then, knowing who to refer to for psych issues. Now, I recognize that there's some limitations in thinking about referring to other providers because, number one, what if there is no one in your community that does that? But I'd encourage you just to seek that out. You might be surprised. There probably are folks that you could partner with that, could be your, I'm going to phone a friend. Can you please help me with this patient that is having persistent issues? And it probably will work in the way that even therapists that I know that are in rural areas, it's not like they want to take your patients away from you and you never see them again. They recognize that medical copays are expensive. So having a way to partner with somebody who's going to see this kid every day in the schools, and you can work together to try and figure out a vestibular rehab program for them is the sort of thing that people are, I think, happy to collaborate with other providers. Okay, so talking about rehab in a half an hour, I was saying earlier to some other folks that that's like a minute for every year I've practiced in rehab, so that's not going to happen. So I just had to be a little bit more kind of leave some things out in order to get to something that hopefully will have some value for you all. So I'm encouraging you to think about the self-report things that you might use, but then also pairing it with objective measures that have some sort of functional relevance. And so I just have picked two areas that I'm just going to talk about briefly, vestibular balance, and then I'm going to talk a little bit about the headache cervicogenic contributions. Because I think that's an area where there's a lot of overlap in symptom complaints, and if you are trying to kind of differentially diagnose what you think is really driving the problem, making sure you get that right is probably an important thing. So as I said before, I've done a lot of work with the DoD, and there's a Defense Centers of Excellence, actually now it's called DivBIC, Defense and Veterans Brain Injury Centers, that has worked to develop clinical recommendations for use in active duty military. And this is a nice resource that you can download for free if you want to take a look at this. It's designed more for primary care, but it may also be beneficial if you want to learn a little bit more about managing dizziness. That helps you really think about some of the factors that might be important to consider. In particular, this idea of the way that dizziness is behaving, because that helps us think about whether we think it's really coming from a canal problem, coming from more of a unilateral kind of hypofunction problem, and that will help determine treatment that's necessary. So I think this is a nice resource to consider. So when I think about the vestibular rehab aspects, often what we're considering are, looking at oculomotor control because of the key interactions between the eyes and the vestibular system to maintain gaze stability. That's an important area to measure. And then there's some specific diagnostic tests. Obviously, I'm not going to go through all of these. But you're really looking here for things that provoke the symptoms in some sort of reliable way that help confirm a hypothesis you have about what you think the problem is. And so those are really important things because your treatment is going to vary based on the diagnosis that you feel you're dealing with. I also feel, especially after you get out of the acute period post concussion, that you need to be thinking about balance measures that move beyond standing still. If you have access to the sensory organization test, that's where you can also do the head shake SOT. That's a way to, it's a little bit more provocative, is used a lot in the military context. When you have somebody that's really high level, the head shake SOT sometimes will draw out a little bit of impairment that might not be evident otherwise. And there are lots of different high-level mobility tests that you could consider. Supplementing with self-reports that are specific to vestibular impairment is another area where there's often need. And then the intervention approach is going to be multifaceted. Training, visual and oculomotor control issues. If someone has a benign paroxysmal positional vertigo, that you're treating that with a positioning maneuver, doing vestibular ocular reflex exercises or habituation work. If someone has motion sensitivity problems. And so these are things that, a neuro-PT that you could collaborate with would be happy to get somebody started on a home program and perhaps suggest ways to advance that. Okay, so cervicogenic. I think it's important to recognize that there are huge overlaps between the common symptom complaints in these two conditions for concussion and whiplash. So Jim Elliott, who does a lot of research in the whiplash arena, and I have this ongoing debate, where I'll be like, Jim, how do you know they don't have a concussion? He'll be like, hey, Mac, how do you know they don't have whiplash? And then we're like, maybe they have both. So it's entirely possible that both of those are contributing to some of the problems that the person has. So we know a lot more now about the role of the neck proprioceptors in kind of supplementing somatosensory information from the body and visual information, vestibular information, and helping us with postural control. And so sometimes people that have a cervicogenic dizziness report just feeling sort of off and like disconnected, and it's not like a spinny sort of vestibular kind of complaint. So if you're hearing that sort of complaint, it could be that there's a cervicogenic component, and finding somebody who's comfortable with looking at some specific tests for stability, ligamentous stability, and then also doing a comprehensive cervical assessment and some of the interventions, including manual therapy that might be important there, may be a good collaborator to have. So, there is some reasonable evidence for use of various interventions to deal with these cervical problems that might be comorbid to someone that has a concussion. So when I think about rehab in general, it's like, well, where do you start with someone that has a TBI? It's complicated. Always that expectation for recovery is something that's there, and normalizing the person's symptoms. So you're providing support and referral that's necessary, and then you're starting with what's on fire, basically. So starting with the chief complaint and trying to address that in a way, and then really thinking about what the reasonable sequence of interventions might be to address impairments that you've been able to find on your physical exam. So as you're thinking about that, it's really important to consider the irritability that the person has with whatever the complaint is, because that's going to be critical in determining the pace of the intervention that you use. So there's some people that, say, I'm dizzy, but they can tolerate a lot of, VRR exercises, and some people that say I'm dizzy and they can do very little, and they're, totally ramped up and don't want to come back and work with you again. So you really have to think about that carefully, and then teach the person appropriate self-management strategies and education about the underlying cause of their symptoms, situations that might provoke them, so that they can continue to progress in their usual routine, return to learn, return to work, return to play, whatever the priority is. So as an example, if you had somebody that presented with this combination, is it neck, is it dizzy, what's the what's the problem and they have pain, you might start with pain management, and this is similar to what we're doing in the active rehab trial, where we're trying to prioritize, manage people's comfort to start with. And if you want to do vestibular rehab, you have to have someone move their head. So if they have cervical problems, you're going to probably need to deal with that first. So think about the sequencing there, so that you deal with the cervical impairments, so then they could tolerate the vestibular rehab. And then, if vestibular rehab exacerbates their cervical symptoms, then you're going to need to modify somehow. And so, it's really going to depend on what the combination of complaints are that people have and the impairments that you see. But thinking about this as a kind of a cyclical thing, I think is a very typical rehab approach. So, when we think about what you want to do in terms of rehab and what the evidence is for rehab, well, the evidence is really pretty crappy right now because there are not a lot of randomized control trials. The one that John is leading is, I think, going to be a really important one to help us understand timing a little bit better, and when you might be able to start with a rehab mindset. Catherine Schneider's randomized control trial, where she did a combination of cervical and vestibular rehab compared to people that are just waiting until they're asymptomatic, showed this decreased time to medical clearance, and there have been some similar results in these other studies that are listed here. But we still don't have great information about exactly the timing, intensity, duration of therapy that's necessary, and what the effects are of that in the long run. But more to come and more work to be done. So I'm about out of time. Actually, I am out of time. It says, time's up, stop talking. But I did just want to mention a little bit about our some of the work that we've been doing that I think there are a lot of people working in this space trying to identify performance-based tests that might have functional relevance in certain contexts. And the niche of active duty military is kind of a special thing because everyone who's in the military has to do certain training maneuvers, including running with a weapon and doing a combat role. And what better way to stimulate the vestibular system than to ask someone to do that, right? So we've been working for since 2008 on a number of different tasks that use dual task measures. We have this run roll task. There's an exertional task. We actually just found out last week that we got another DoD grant to fund study of this 3 subtest approach. And we're using movement assessment with accelerometry and gyros on smartphones. So we just put a smartphone on the person and have them do this task. And are trying to also integrate more physiologic measures that would be sort of performance-based biomarkers that would help you be able to compare to sort of normative performance to try and make decisions about, in this case, return to active duty, which you could question whether it's ever safe. But anyway, so look for work that people are doing in this this sort of vein, because I think there may be some things that also have more civilian application, especially our exertional task is one that may, and the dual task agility task may be something that people could use also in a sports context. So just to finish up, you need to expect heterogeneity in the presentation of individuals that have TBI that need rehab, and also expect heterogeneity in their responses to intervention. I'm not sure that it's ever going to be something that can be done by protocol. So remember, don't go it alone, because this is what happened to the Black Knight. I'm not going to bleed on you. All right, thanks.